Hello everyone. Welcome back to the series of lectures in medicine. This is Dr. Maitri. From today, we will be starting off with another very important and interesting section, which is your endocrinology. So to start off with endocrinology, we will first be discussing the important chapter on the physiology of anterior pituitary and hypopituitarism. So let's begin. So what is the pituitary gland? The pituitary gland is basically an endocrine gland which has a weight of about 50 to 60 grams. This has a weight of about 50 to 60 grams and it is located in the sella turcica on the sphenoid bone. Right? So it is located in the sella turcica on the sphenoid bone. Okay? So the pituitary is a very small gland and this is directly under the control of another portion of the brain, which is your hypothalamus. So the hypothalamus is not in essential considered to be an endocrine gland, but the pituitary is under the control of the hypothalamus and this is called as the hypothalamo-pituitary axis. So the pituitary basically comprises of two lobes, which is the anterior lobe and the posterior lobe. Okay, so it comprises of two lobes, which is the anterior lobe and the posterior lobe. The anterior lobe is involved in the secretion of a different group of hormones and the posterior lobe is involved in the secretion of another group of hormones, which we will be looking at. The pituitary circulation is basically a portal circulation. What do you mean by portal circulation? Portal circulation basically means that the circulation basically begins and ends in capillaries. It begins and ends in capillaries. Okay. So if you see that this is the hypothalamus, this is the stalk with which your pituitary is connected, anterior lobe and posterior lobe. So if you see the circulation, it begins as capillaries and it ends as capillaries. So the substances which are carried from the hypothalamus to the pituitaries, they are carried via this kind of a portal circulation. Okay, so this is about the basics of your pituitary, right? How does the pituitary develop? The pituitary basically develops from what we call as the Rathke's pouch, which is an invagination of the third ventricle. Okay, it develops from the Rathke's pouch, which is basically an invagination of the third ventricle. So the neurons from the third ventricle migrate towards the Rathke's pouch and from the Rathke's pouch the pituitary gland develops. Okay, so the pituitary gland is involved in literally the production of all the hormones. Literally all the other endocrine glands are under the control of the pituitary gland and hence this is also called as the master gland. It's also called as the master gland. Okay, fine. Now let us see what are the hormones and how is the pituitary controlling them. So I told you that the pituitary is basically under the control of your hypothalamus. So the hormones or substances which are released from the hypothalamus are called as your releasing hormones. Okay, because they stimulate the pituitary to actually release the hormones which are required for the functioning of all the other endocrine glands. Fine. So the hypothalamus basically secretes, let us look at all of the hormones one by one. So the hypothalamus basically secretes your CRH, which is your corticotropin releasing hormone, which goes to the anterior pituitary and it further causes stimulation of production of adrenocorticotropic hormone, ACTH, which then acts on the adrenal gland. The target organ is the adrenal gland, which is involved in the production of the hormone cortisol. So the first group of hormones is your CRH, which causes stimulation of ACTH. ACTH is produced from the pituitary. CRH is produced from the hypothalamus. This acts on the adrenal gland. Second, we have your thyrotropin releasing hormone. Okay, TRH stands for thyrotropin releasing hormone, which is produced from the hypothalamus and this causes stimulation of the thyroid stimulating hormone, which is produced from the pituitary and this causes actions on the thyroid gland. It causes actions of the thyroid gland. Third, we have the GnRH. GnRH is gonadotrophin releasing hormone. So, gonadotrophin releasing hormone is secreted by the hypothalamus, and this goes to the anterior pituitary and it causes release of gonadotrophins. Okay, this causes release of gonadotrophins, which further causes stimulation of your ovaries and testes. Okay, so it acts on the ovaries or in the testes. Then you have your GHRH, which is your growth hormone releasing hormone released from the hypothalamus, which causes secretion of growth hormone, and this growth hormone has actions on in the liver or in the bone. Okay, then we also have the production of prolactin, which is responsible for lactation. Okay, so what are all the hormones which are produced by the anterior pituitary? What are all the hormones which are produced by the anterior pituitary? So this includes growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, gonadotrophins and prolactin. Okay, so these are the hormones which are secreted by the anterior pituitary. Okay, what are the hormones which are produced by anterior pituitary? They are your growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, gonadotrophins and prolactin. Now, what are the hormones secreted by the posterior pituitary? The posterior pituitary secretes two hormones, which is your oxytocin and vasopressin. Okay, oxytocin and vasopressin. What are the functions of these? We will be looking at in our chapter on posterior pituitary. Right? So, this is about the anatomy and this is about your hypothalamo-pituitary axis. Okay, fine. Now, let us look at each of these much more in detail. So, this is your anterior pituitary. So, this is your anterior pituitary. So, your anterior pituitary has 5 groups of cells. These cells are your corticotropes, somatotropes, lactotropes, thyrotropes and gonadotropes. Okay, so the corticotropes are basically involved in the production of ACTH, which stimulates the adrenal gland. Somatotropes are involved in the production of growth hormone. Lactotropes are involved in the production of prolactin. Thyrotropes is thyroid stimulating hormone and gonadotropes are involved in the production of gonadotropins. Okay, so we'll be looking at in detail. So, what is the developmental factors responsible for each of this? Okay, so the developmental factor involved in the growth of corticotropes is your T-pit. Okay, you just have to remember T-pit. The developmental factors which are involved in the development of somatotropes, lactotropes and thyrotropes are your PROP1 and PIT1. And remember, SF1 and DAX1 are involved in the development of gonadotropes. So, we have T-pit for corticotropes, SF1, DAX1, gonadotropes. These two you remember, and the others are PROP1 and PIT1 are involved in for the others, somatotropes, lactotropes and thyrotropes. Okay. So, what is the production or the hormone which is produced by your corticotropes? It is your POMC, which is your pro-opiomelanocortin and ACTH. Fine. Then, under your somatotropes, what does it produce? It produces growth hormone. Lactotropes, which are there in your anterior pituitary, are involved in the production of prolactin. Thyrotropes is TSH and gonadotropes is FSH and LH, which is your gonadotrophins. Fine. So, the first three, which is your ACTH, GH, prolactin, all are polypeptides. TSH, FSH and LH are glycoproteins. Fine. Where is the action? ACTH basically acts on the adrenal gland. So, ACTH acts on the adrenal gland and it is involved in the production of cortisol. It is involved in the production of cortisol, which is a stress hormone. Then, where does the growth hormone act? Growth hormone, as the name suggests, is responsible for growth. So, it acts on the bone, it acts on the liver as it has some metabolic functions as well. Lactotropes basically produce prolactin, which acts on the breast. So, this is responsible for milk production. So, it is involved in lactation. Lactotrope basically produce prolactin, which is involved in lactation. Then, TSH acts on the thyroid gland and it is involved in the production of T4. And gonadotrophs are basically your FSH and LH, which acts on the ovaries and testes, and they are involved in the production of sex steroids. Okay. Now, we should remember that this is the hypothalamus. Okay. This causes stimulation of the pituitary, which is basically your anterior pituitary, and this in turn produces hormones which basically act on the various endocrine glands. So, the products which are produced as a result of it have feedback inhibition on the pituitary and the hypothalamus as well. Right? So, the products which are produced have feedback inhibition on the pituitary and the hypothalamus as well. So, what are the corticotropes, or what is ACTH inhibited by? It is inhibited by glucocorticoids, right, which is basically the product which is formed itself. Insulin-like growth factor and somatostatin are inhibitors of your growth hormone. Dopamine is an inhibitor of prolactin. T3, T4 glucocorticoids, all of them can have feedback inhibition on T3, T4 have feedback inhibition on TSH. Glucocorticoids can also inhibit TSH. Then we have another product which is formed, which is inhibin. Inhibin itself has a feedback inhibition on your FSH and LH. Okay. So, I hope this is clear. This is your physiology of anterior pituitary. So, let us just revise this once more. So, what is the pituitary? The pituitary is an endocrine gland which is about 50 to 60 grams located in the sella turcica, and this is basically developed by your invagination of the third ventricle from your Rathke's pouch. This is a small endocrine gland which is under the control of the hypothalamus. However, it is involved in the control of all the other endocrine glands, and hence it is called as the master gland. The pituitary has two lobes, the anterior lobe and the posterior lobe. The anterior pituitary is involved in the production of growth hormone, ACTH, TSH, gonadotrophins and prolactin. Posterior pituitary is involved in the production of oxytocin and vasopressin. Okay. So, we have releasing hormones which are produced from the hypothalamus, and then you have stimulating hormones produced from the pituitary, which further acts on various endocrine glands. Right. So, this is about your physiology of anterior pituitary. Now, let us look at the functions of each of these hormones in detail. So, let us look at the prolactin. So, prolactin is basically responsible for lactation. So, in postpartum women, the lactation is basically brought down by prolactin. Okay. What are the other functions of prolactin? In a postpartum woman, the body itself has designed them in such a way that they do not have to undergo another reproductive cycle, right? So, it suppresses the reproductive function. It causes an ovulation and it causes suppression of GnRH as well. So, prolactin not only helps in lactation, it suppresses the reproductive function and causes inhibition of gonadotropin releasing hormone. So, if gonadotropin releasing hormone is not released, then there is no FSH and LH. Their reproductive functions will not happen. That is the reason why in your postpartum period, the lady can have amenorrhea for a long time, up to 6 months. Okay, they can have amenorrhea for a long time. And this prolactin is basically inhibited by dopamine. It is basically inhibited by dopamine. In this context of prolactin, a very, very important effect that we have to learn is called as your pituitary stalk effect. Okay. So, what is the meaning of this pituitary stalk effect? So, let us understand this. Now, this is your hypothalamus and this is your pituitary. Okay, so we have the hypothalamus and the pituitary. Now, similar to all the other hormones which are being carried, dopamine is also carried from the hypothalamus to the pituitary. Okay, dopamine is a neurotransmitter and dopamine is carried from the hypothalamus to the pituitary. What is the function of this dopamine? It basically inhibits prolactin. Now, in certain conditions where there can be a tumor from the pituitary gland, a tumor arising from the pituitary gland. Okay, so let us consider that this is a pituitary adenoma. This is a pituitary adenoma or a tumor arising from the pituitary gland. Now, this tumor can grow upwards and cause compression of the pituitary stalk. The pituitary stalk is basically the structure that connects the hypothalamus and the pituitary, right? So, this pituitary adenoma can cause compression of the pituitary stalk. So when there is compression of the pituitary stalk, then what happens? The dopamine transport does not happen. So the dopamine does not get transported. So if there is no dopamine, then what happens? The inhibitory effect on prolactin is lost. The inhibitory effect of dopamine on prolactin is lost. So if this is lost, what happens? The prolactin begins to increase, right? So what does this mean? That in a patient with pituitary adenoma, if the pituitary adenoma, especially a macroadenoma, enlarges and can cause some compression on the pituitary stalk, then you can have hyperprolactinemia. You can have hyperprolactinemia. Why is that so? Why is that so? It is not because of excess production of prolactin from your pituitary gland. That is a different issue. Okay. This is because the inhibitory effect of dopamine on the prolactin is lost. So this is what we call as the pituitary stalk effect. So this phenomenon is very, very important because it helps in the diagnosis of certain conditions. Okay. So we will be looking at this again in your pituitary tumor syndrome. So this is a very, very important effect, which is your pituitary stalk effect. Now let us look at the function of growth hormone. So growth hormone is also another hormone which is produced from the anterior pituitary. This is involved in protein synthesis. Okay. This causes antagonization of insulin action. That means what? It can cause hyperglycemia. It can cause hyperglycemia. It is involved in lipolysis. It is involved in lipolysis. It increases the lean body mass and it helps in water retention and bone growth as well. Okay, growth hormone predominantly acts via insulin growth-like growth factor. So, growth hormone predominantly acts via another hormone which is your insulin-like growth factor. Okay, so it's involved in protein synthesis, lipolysis, it increases the lean body mass, but it does have insulin antagonizing action and helps in bone growth. Fine. Then we have the adrenocorticotropic hormone. This is produced by CRH, right? Similarly, growth hormone, releasing hormone from the hypothalamus causes release of growth hormone. So, CRH basically is responsible for the production of ACTH. ACTH, which is produced from the pituitary, goes and acts on the adrenal gland. The adrenal gland then produces cortisol, okay, which is involved in your stress response. We know that the adrenal gland basically has three layers, the medulla and the cortex. The cortex has an outside zona glomerulosa. So let us look at the layers of the adrenal cortex. So the cortex again is divided into three layers. So we have the outer zona glomerulosa. Outer zona glomerulosa, which is involved in the production of, so we have an outer zona glomerulosa which is involved in the production of glucocorticoids. Then we have the middle zona fasciculata, which is involved in the production of mineralocorticoids. Mineralocorticoids is nothing but your aldosterone, which is responsible for your volume status. Okay. Then we have the inner zona reticularis, which is involved in the production of sex steroids. Okay. So the whole point is that corticotropin releasing hormone released from the hypothalamus is responsible for the production of adrenocorticotropic hormone from the pituitary. ACTH causes release of cortisol. Cortisol from where? It causes release of predominantly your glucocorticoids from your zona glomerulosa. It is responsible for production of glucocorticoids. The mineralocorticoids are under the control of the renin-angiotensin-aldosterone system, right? So it's predominantly involved in the production of glucocorticoids. And when are these glucocorticoids required? They are required in your flight and fight response. For example, this is mainly responsible for your stress reactions in the body. Okay. Then we have your gonadotropin releasing hormone. Okay. The gonadotropin releasing hormone basically causes release of your gonadotrophins, which is your FSH and your LH. FSH is follicle stimulating hormone and your luteinizing hormone. So the FSH in the males acts on the Sertoli cells and is responsible for somatogenesis. The LH in the males acts on the Leydig cells responsible for production of testosterone. In the females, it is mainly responsible for maintaining your menstrual cycle. It helps in ovulation. It helps in ovulation. So we know that the LH surge is the one which is responsible for ovulation. Okay. So this is about the various functions of the anterior pituitary. Okay. And very, very importantly, we have learned what is this pituitary stalk effect. Okay. So let's move on to hypopituitarism. So what exactly is hypopituitarism? Sometimes due to many conditions, there can be a deficiency in all of these hormones or one or more of these pituitary hormones. So whenever there is a deficiency of one or more of these pituitary hormones or all of these pituitary hormones, it is called as hypopituitarism. Okay. So let us look at the various etiologies for hypopituitarism. So first, we have understood that the pituitary gland is basically a gland that develops from the Rathke's pouch, which is an imagination of the third ventricle. So any disorder in the embryological stage with the development of the Rathke's pouch or any disorder which involves your midline craniofacial defects, this can cause hypopituitarism. So first group of disorders or first group of etiologies for hypopituitarism that we are looking at is the developmental structural disorders, right? So midline cerebral defect syndrome can cause hypopituitarism, right? So what are the midline cerebral defects? These are basically your midline cranial defects, and they can be acquired causes which can cause damage of your midline cranial structures. For example, breech delivery or asphyxia. Okay. So this is one of the developmental causes for hypopituitarism. Okay. Then let us look at the other conditions. Pituitary dysplasia or pituitary aplasia. So during your embryological stage itself, there are a lot of genetic factors which are involved in your pituitary cell production, right? So we looked at those genetic factors in the physiology of anterior pituitary. We have learned of TPIT, we have learned of SF1, DAX1 and so on. So any of these disorders or any of these growth factors, if they are affected, you can have developmental disorder of your pituitary. So let us look at that. Okay. So PIT1 or PROP1 defect. We have learned about PIT1 and PROP1. They are involved in the growth of which group of cells? It is your growth hormone or your somatotropes. We'll write it as somatotropes. Then lactotropes and your thyrotropes. Right? So lactotropes produce prolactin, thyrotropes produce TSH. So they can have growth hormone, prolactin or TSH deficiency. Then TPIT is a transcription factor involved in the growth of which group of cells? It is your corticotropes. So if there is a TPIT deficiency, then they present with adrenal insufficiency because ACTH is not produced. SF1 and DAX1 are transcription factors involved in what? They are involved in the production of gonadotropes. Right? So they can have gonadotropin deficiency. They will have no FSH and LH production. Okay. So that is about how the different growth factors, if they are involved, it can cause hypopituitarism. Then certain other genes that we have to remember whenever there is a developmental disorder of the pituitary. So first we have your HESX1. Okay, HESX1 is associated with septo-optic dysplasia. It is a little difficult to remember, but I can give you clues to remember these group of genes. So remember S and S. So HESX1 is septo-optic dysplasia. Then SOX2 or 3. SOX2 or 3. So SOX2 or 3 is basically involved in corpus callosal agenesis. A very interesting way to remember this is you remember a SOC, right? So SOC is basically standing for SOX2 or 3, which is your gene. Now if you make the SOCs like this, you make your SOC horizontal, what does it look like? It looks like the corpus callosum. Okay, this is just a easy way to remember this. So SOX2 or 3 is associated with corpus callosal agenesis. Then the next gene is your 6-6. So 6-6 is associated with anophthalmia. Okay, so you know that how do you basically denote vision whenever you do a analysis of your visual acuity? You would denote it as 6/6, right? So you remember 6/6. So 6-6 is associated with vision, 6/6. So 6-6 gene is associated with anophthalmia. Okay, so these are easy ways to remember the genes. Then LHX3, you have to remember the characteristic feature that's associated with rigid spine or limited neck rotation. So all of these are basically genetic disorders which can cause hypopituitarism because of growth factor defects and genetic problems. Okay, the next group of disorders which can cause hypopituitarism is your congenital hypothalamic disorders. So what are the congenital hypothalamic disorders? We'll be looking at one by one. So the most important is your Kallmann syndrome. Kallmann syndrome is basically an X-linked disorder which is associated with a problem with the Cal gene. Okay, so the gene involved is the Cal gene. So what are all the features? They have hypopituitarism and predominantly they have GnRH deficiency. So this is one of the cause for hypogonadotrophic hypogonadism. So what is the meaning of that? What is the meaning of hypogonadotropic hypogonadism? This means that the deficiency is at the level of hypothalamus itself. Gonadotropins only are not produced. That is why you do not have FSH and LH. Okay. So there is GnRH deficiency, that is because of the problem with the hypothalamus. And there is olfactory bulb agenesis resulting in anosmia. So what are we discussing now? We are discussing about the etiology of hypopituitarism. We have learnt about the developmental and disorders and the genes that are involved. Now we are looking at hypothalamic causes, right? So hypothalamic disorders which can cause hypopituitarism because the pituitary is under the control of hypothalamus. Okay, so Kallmann syndrome is basically an X-linked disorder because of a genetic defect in the Cal gene. It's associated with hypogonadotrophic hypogonadism and anosmia because of olfactory bulb agenesis. The second syndrome is your Bardet-Biedl syndrome. This is characterized by intellectual disability, obesity, renal abnormalities, brachydactyly, central diabetes insipidus and retinitis pigmentosa. RP is retinitis pigmentosa. Retinitis pigmentosa is basically a disorder of your retina where you have some blackish deposits which are seen and finally they have loss of vision. So Bardet-Biedl syndrome, intellectual disability, obesity, renal abnormalities, brachydactyly. Then the other hypothalamic disorder is your Prader-Willi syndrome. Again there is hypogonadotrophic hypogonadism, obesity, hypotonia and they have a risk of adult onset diabetes. They have a risk of adult onset diabetes. Okay. So with this we have understood what are the developmental, structural and other genetic causes for hypopituitarism. Okay. So we have discussed about genetic causes as well, combined or isolated pituitary hormone deficiencies depending on different growth factor involvement like TPIT involvement, PROP involvement, PIT1, SX1, DAF1 and so on. Okay. Then the second group, the second etiology, for example, surgical resection, radiotherapy, head injuries. So when do you do a surgical resection? So if you have a pituitary adenoma and the patient has undergone a surgery, post-surgically they can have complete damage to the anterior pituitary and they can have hypopituitarism. Okay. Then neoplastic causes like pituitary adenoma, paracellular masses like germinoma, Rathke's cyst, craniopharyngioma, hypothalamic tumors including hamartomas, gangliocytomas. Also remember that the pituitary can also be a site of metastasis. So what are the malignancies which basically metastasize to the pituitary? They are the breast cancer, lung, colon cancer. Breast cancer, lung and colon cancer can metastasize to the pituitary and cause hypopituitarism or basically pituitary hormone deficiency. Then lymphomas, meningiomas. Okay. The next group is basically your infiltrative or inflammatory disorders. So there can be infiltration or inflammation in the pituitary. So what does that mean? So there can be autoimmune disorders. There can be autoimmune disorders of the pituitary. Most importantly, your lymphocytic hypophysitis. So what is hypophysitis? Hypophysis is basically another name for the pituitary gland. So hypophysitis, anything with itis means inflammation. So an autoimmune disorder where there is inflammation of the pituitary gland causing hypopituitarism is your lymphocytic hypophysitis. We will be discussing it in detail in the further coming up slides. Then infiltrative processes like hemochromatosis where there is excessive iron deposition. This iron can deposit in the pituitary as well. Then sarcoidosis. Then certain immunotherapies, especially cancer-related immunotherapies. So newer anti-cancer medications including your CTLA4 inhibitors or your programmed death cell ligand inhibitors. So these are newer anti-cancer therapies which are being done. But these drugs can cause hypophysitis, which is an immune-mediated hypophysitis, and hypopituitarism can happen. Then vascular causes for hypopituitarism. This includes pituitary apoplexy. Apoplexy means there is a sudden cutoff of blood supply to the pituitary. This can happen in postpartum, it can happen in severely hypertension patients, or it can happen in sickle cell anemia where there is a bleed into the pituitary and you can have apoplexy and you can have hypopituitarism. Then subarachnoid hemorrhage, arthritis. 6. There can be infections which can affect the pituitary. Yes, there can be infections, especially in immunocompromised. For example, fungal, parasitic, tubercular. Okay. So these are all of the various etiologies for hypopituitarism. So we have learnt of developmental etiologies, genetic factors, we have learnt of post-traumatic, post-surgical radiotherapy and so on. Then masses in the pituitary, tumors in the pituitary, metastasis to the pituitary. We have learnt of infections, we have learnt of inflammation and infiltrative causes, and we have learnt of vascular causes like pituitary apoplexy. So this is about the various etiologies for hypopituitarism. Okay, fine. Now let us look at the acquired causes. Amongst the acquired causes, there are two important conditions which require a differentiation and which is of importance to highlight here. So one is your lymphocytic hypophysitis and the second is your pituitary apoplexy. So lymphocytic hypophysitis, just now we had discussed, is basically an autoimmune condition. So this is an autoimmune condition. Apoplexy is basically a vascular condition. So which group of individuals and why should we know that we have to differentiate between both of them? See, both apoplexy and lymphocytic hypophysitis are common in postpartum women. Okay, so both are common in postpartum women. Pituitary apoplexy can also be seen in pregnancy, in hypertension, sickle cell anemia. It can be seen in hypertension and sickle cell anemia as well. Okay, so what is the basic pathological difference? Both of them are seen in postpartum individuals. Both of them can present with hypopituitarism. So basic pathological difference is that in lymphocytic hypophysitis, there is an autoimmune trigger and there is lymphocytic inflammation of the gland. Right? So there is inflammation of the gland. And very importantly, this can mimic a pituitary adenoma. This can mimic a pituitary adenoma. So because of the inflammation, the pituitary gland will be enlarged. The pituitary gland will be enlarged and it can mimic a pituitary adenoma. Okay. Now, because of the pituitary gland enlargement and the mimicking of a pituitary adenoma, how do they present? So, a postpartum patient will present with symptoms similar to a pituitary adenoma with headache or a vague kind of vomiting if it is causing compressive effects, right? Because of raised intracranial pressure and compressive effects, you can have vomiting, you can have visual disturbances as well. Now, in apoplexy, what is the basic pathology and how do they present? So, in apoplexy, the basic pathology is vascular in nature. So, in a postpartum patient with pituitary adenoma, there can be a sudden bleed. Now, because of this sudden bleed, this also occurs in a postpartum woman. This also can cause hypopituitarism. There can be a sudden bleed and these patients usually they do not present insidiously. They present with a sudden onset of shock. they go into shock and they are very, very sick because of the sudden bleed. There is a complete loss of ACTH, right? Adrenocorticotropic hormone is lost and cortisol is lost, and hence the blood pressure drops precipitously. The blood pressure drops precipitously. Okay, right? So this is how these two differ. Lymphocytic hypophysitis presents more insidiously, whereas apoplexy presents more suddenly. But what are the common features? The common features are both are seen in postpartum women. Both can have a pituitary adenoma-like presentation, and both can have hypopituitarism. Okay, so both can have hypopituitarism, pituitary adenoma-like presentation, and both can be seen in postpartum women. But apoplexy presents with more drastic changes. They present in shock. But lymphocytic hypophysitis predominantly presents with headache, vomiting, visual disturbance. Right? So the one important clinical feature which helps in differentiating, the lab test which helps in differentiating, is your prolactin. So what happens in lymphocytic hypophysitis? So I told you that this can mimic a pituitary adenoma itself. So if you do an MRI, you will still not know whether this is a pituitary adenoma or not in a postpartum women, and in fact you may even want to do a surgery. So the only way that you can differentiate it is that because this is similar to a pituitary adenoma, it presents as a mass and it grows and compresses what? It compresses the pituitary stalk. It compresses the pituitary stalk and it can cause pituitary stalk effect. So it can grow in size and compress the pituitary stalk and cause pituitary stalk effect. So when the pituitary stalk effect happens, what happens? The inhibitory effect of dopamine on prolactin is lost, and hence the prolactin will be elevated. But in pituitary apoplexy, what happens? There is a complete loss of all the hormones. Especially in a postpartum women, you can have lactation failure as well. And hence the prolactin levels will be decreased. in pituitary apoplexy. Okay, fine. And since lymphocytic hypophysitis is an inflammatory condition, the ESR will be elevated. What is the treatment for lymphocytic hypophysitis? In the inflammatory condition, you can treat it with steroids. Okay, and your apoplexy, it is a very, very serious condition. So you have to stabilize the patient. And you treat them with hormone replacement. You will have to treat them with hormone replacement. First you give them steroids. So what steroids you give? You give them hydrocortisone. So hydrocortisone is started at a dose of around 100 mg 8th hourly. Okay, you give it as a 200 mg stat dose, and then you give it at 100 mg 8th hourly, so that you bring up the blood pressure. Okay, followed by which you once they have come out of the shock phase, come out of the critical phase, then you may have to give some mineralocorticoid replacement as well. Okay, fine. And if the bleed is very, very high, and suppose they are in an altered sensorium because of some mass effect and so on, then you will have to take up the patient for a surgery. Okay, so this is about your lymphocytic hypophysitis versus your pituitary apoplexy. So the most important take home messages is that both of them can present in postpartum patients. Both of them can appear like a pituitary mass, right? And both of them basically can cause hypopituitarism. The underlying difference is that in lymphocytic hypophysitis, because of the mass effect and it's more indolent, prolactin will be high because of pituitary stalk effect, because of compression in the pituitary stalk. In your apoplexy, if it is a pregnant patient with pituitary adenoma who has bled, then you will have a complete loss of all the hormones and the patient is much, much sicker. Okay, fine. So now let us look at the clinical features of hypopituitarism. Okay, so first, the clinical features of hypopituitarism depends on how rapidly the symptoms have developed. So is it a acute problem? Whether the hypopituitarism has developed acutely or whether it has developed over time. right? So if the rapidity of onset of the hypopituitarism is faster, if it is more rapid, then it is more symptomatic and it is more severe, right? But if the hypopituitarism has been going on for a long time, if it is chronic, if it is indolent, then the symptoms are little different. So an example of the acute onset rapid hypopituitarism is your apoplexy. Chronic ones can be because of slow growing tumors, or for example developmental defects. Okay. So if there has been an acute onset of hypopituitarism, how will it present? Just now we had discussed in apoplexy that there can be a catastrophic vascular collapse. There can be a catastrophic vascular collapse and they will be in shock, mainly because there is complete loss of ACTH. Okay, this is because of your steroid deficiency. But if the steroid deficiency has been going on little slower, then if the ACTH deficiency is going on little slower, then they can present with symptoms of chronic steroid insufficiency. So chronic adrenal insufficiency, which basically presents as weakness, okay, lassitude, recurrent episodes of hypoglycemia. They do not have shock. Okay, you can have hyponatremia as well and hyperkalemia because of mineralocorticoid deficiency. Okay, fine. So that's about your steroid deficiency. Then the other symptoms are dependent on what are the other hormones which are deficient. So in your slow or indolent onset hypopituitarism, if there is growth hormone deficiency, then in children you can have restricted growth and you can have short stature. So many of these developmental disorders, hypothalamic disorders, the children are of short stature because of growth hormone deficiency. If there is thyroid hormone deficiency, then what are the symptoms you can have? You can have weight gain, you can have fatigue, okay, you can have dry skin, constipation and other symptoms of hypothyroidism. Then if there is gonadotrophin deficiency, then you can have infertility. Okay, this happens in adults, but if it happens in children, so if there is gonadotropin deficiency, what happens? There can be failure of ovulation, and there can be amenorrhea. There in your females. In males, there can be loss of spermatogenesis and infertility. Okay, so this is about how various hormonal deficiencies can present. Now, in your apoplexy, especially if it is a postpartum lady, then you can have complete lactation failure. As well. Okay, so this is about the various clinical features of hypopituitarism. Now, let us understand the various tests which are done for hypopituitarism. So, this depends on if you know the physiology of your hormones well, you will be able to understand these tests well, right? So, if there is a deficiency, the basic principle in endocrinology is that you give substances that stimulate the hormone and see if the response is okay, right? So, if you are testing for any deficiency, you give substances that stimulate the hormone or increase the release of the hormone and then look for the response. So, how do you check for growth hormone? There are 2-3 tests which are done. You know that growth hormone is stimulated. It is stimulated by arginine. It is stimulated by dopamine. Okay, and it is stimulated by insulin. That is the reasons why we use insulin tolerance test. Then we use L-arginine test and an L-dopa test. So, in the insulin tolerance test, what do? We give regular insulin IV, okay, at a dose of about 0.15 units per kg. And then we check for the growth hormone levels and the glucose levels. Okay. So, if your growth hormones is intact, if your growth hormone deficiency is absent and your hypothalamo-pituitary axis is intact, you take blood samples at 30, 60, 120 minutes for glucose and growth hormone. And normally if you give insulin, the growth hormone rise should be to more than 3 picogram per ml, and because you are giving insulin, you should induce a hypoglycemia. So this is your insulin tolerance test. Then you have your L-arginine, L-dopa test, and all of these are basically substances which can be given IV. After 30 or 60 or 120 minutes, you check for your growth hormone levels, and normal response is that the growth hormone should be more than 3. If there is no response, that means that there is a growth hormone deficiency. Right? So this is how you diagnose growth hormone deficiency. Then prolactin, you give a TRH test, which is your thyrotropin releasing hormone, and similarly you look for prolactin and TSH at 30 or 60 minutes. Normally the prolactin has to rise to a level more than 2 and increase of more than 200% from the baseline. If it does not happen, there is prolactin deficiency. Then for ACTH, this we will be looking at in detail in your chapter on adrenal disorders and Cushing syndrome. So we can do a CRH stimulation test, a low dose ACTH test, and a other 3-day ACTH stimulation test. Okay. So what do we check there? We look for a cortisol response, and the cortisol should raise to more than 21 microgram per deciliter. We look at the cortisol levels, and the cortisol levels, if they are more than 21, this means that the hypothalamo-pituitary adrenal axis is intact. Then for TSH, we can use a TRH test, and again we look for the rise of TSH after administration of thyrotropin releasing hormone, and the TSH should rise by more than 5. For LH and FSH, again we can do basal measurements, and you can do a GnRH test. Okay. So these are the various type of stimulation tests which we use for the diagnosis of hypopituitarism. Now let us look at the treatment. So treatment basically involves, if it is an apoplexy, if it is very acute, patient is very sick, then you have to stabilize the patient and start them on steroids, hydrocortisone, because that is the reason, steroid deficiency is the reason why they go into vascular collapse and shock. So this is given as 200 mg IV stat, and you give them 100 mg 8 hourly till they recover. Now once they have recovered and you have started tapering your hydrocortisone, because this is a central cause for your hormone deficiency or cortisol deficiency, you will have to give a mineralocorticoid replacement as well. Okay. Then depending upon the other symptoms, you may have to start the patient on thyroid replacement, you may have to start the patient on growth hormone replacement if this is a child, and if they have lactation failure, you may have to supplement them with other hormones as well. Okay. So the treatment of pituitary deficiency basically involves replacement with different hormones depending upon which hormone is lost. Okay. So this brings us to the end of our chapter on hypopituitarism. We have learnt about the different etiologies, we have learnt about how to differentiate and what are the characteristic clinical features of each of these group of disorders. We have understood how to differentiate between lymphocytic hypophysitis and pituitary apoplexy. We have looked at the clinical features, diagnostic tests and management. In the next session, we will be discussing about the disorders of growth hormone. Thank you.